Hello everyone. Let us now start the discussion of pediatric pulmonology. We'll be starting with the basics and congenital malformations, moving towards infections, and finally we'll be finishing with the lower respiratory tract. We'll be talking about pneumonias and cystic fibrosis. So let us start with the discussion. Now there are many ways of classifying the respiratory tract. One popular way of classifying the respiratory tract is into three parts, the so-called pediatric clinical classification. So the pediatric clinical classification says that suppose this is a child, so this is the respiratory tract, then you have right and left bronchus after carina, and these are the lungs, right? So this entire respiratory tract can be divided broadly into three zones. So first zone is the one which is outside the thoracic cavity, that is part of respiratory tract in the head and neck region, starting from external nares till it enters into the thorax. That all part is called as, it is labeled as, that all part is labeled as extrapulmonary, extrathoracic, outside the lungs, outside the thorax. The second part is the one which is inside the thoracic cavity but outside the lung parenchyma and the interstitial spaces of the lungs. It includes your major bronchus, right and left bronchus, their branches and terminal bronchioles. This whole part is called as intrathoracic, extrapulmonary, intrathoracic, extrapulmonary. And the third part is that of the lungs themselves. We call them as pulmonary, also sometimes written as parenchymal. The pulmonary or parenchymal part includes the gas exchange areas and it includes the interstitial spaces of the lungs. So these are the three whole divisions. Why have we divided like this? Because any pathology in extrapulmonary extrathoracis is commonly associated with the type of sound called as stridor. Any pathology in the intrathoracic extrapulmonary segment is associated with a sound known as wheeze, also synonymously used with the rhonchi. And any pathology in the pulmonary or parenchymal part is associated with a type of sound called as either crepitations or grunting. So, the type of sound helps us in localizing the site of pathology. For example, if you have a question or a patient coming to you with wheezing, you can be sure that the location of the disease is outside it is inside. You can be sure that the location of the disease is not in head and neck region, nor is it inside the lung parenchyma, the alveoli. They are spared. It is mainly the bronchus or the bronchioles which are getting involved, because wheezing is produced in intrathoracic extrapulmonary segment, which includes the bronchus, its branches and the bronchioles. So this categorization is useful in that scenario. So this is the old NEET PG question has been asked on this categorization, so we have discussed it here. Now before we move to individual diseases, there are a few sounds in respiratory tract that we need to remember. What are the sounds and what are the key things that you need to remember? First thing is stridor. Stridor is usually inspiratory. It is an inspiratory sound. Rarely it can be biphasic. Biphasic means both inspiratory and expiratory. And stridor indicates usually involvement in the upper airway. Partial obstruction in the upper airway. Complete obstruction will not produce any sound. Then you have wheeze. Wheeze is usually an expiratory sound and it indicates a partial obstruction in the bronchi or the bronchus and bronchioles. Third sound that we have is rattling. It is not mentioned here, but the rattling is a kind of sound which is due to secretions in the tracheobronchial tree. Rattling can be inspiratory or expiratory. What is rattling sound? What does it indicate? Is a old MCQ already asked in the past. So I am labeling it here. The fourth thing is grunting. Grunting is again an expiratory sound. produced due to sudden closure of glottis. But the disease location is not in the glottis, it indicates alveolar pathology. So alveoli are diseased, particularly, especially collapse or tendency to collapse. Remember that in patients who have hyaline membrane disease, there will be grunting in the newborns. Even ARDS patients will present sometimes with grunting. Now, what exactly is grunting? Suppose there is a tendency of airway to collapse, alveoli to collapse. To prevent collapse from occurring, the child will try to generate a positive pressure inside the entire airway, and this he does reflexly by causing sudden closure of glottis during expiration, producing a sound like this. It is during expiration that there is sudden closure of glottis, and this is a nature's way of ensuring that the collapse does not happen. So, grunting, if question says where it is produced, it is expiratory sound produced at the level of glottis. But what does it indicate? It indicates collapse of the alveoli or impending collapse of the alveoli. And remember, NEET PG MCQ, presence of grunting is a sign of severe lower respiratory tract illness. Which of the following indicates lower respiratory tract illness severity? The answer is grunting. It is a sign of severe illness. And finally, we have a sound. We have a sound called as crepitations. Crepitations usually do not show pattern, fixed pattern with inspiration or expiration, so we don't usually comment upon that. Books will say, but traditionally we do not comment upon it. Crepitations indicate the presence of either a alveolar pathology or interstitial lung disease. Alveolar pathology can be in the form of pulmonary edema, which can be interstitial or alveolar edema. It can be seen in mucus collection in the alveoli like pneumonia. It can even be seen in pulmonary hemorrhage where there is blood. So, anything inside the lumen of the alveolus or around the lumen in the interstitial region will have a tendency to produce crepitations. So, these are the abnormal sounds and what do they indicate? So, after these basics in mind, let us now begin with the proper discussion of pediatric pulmonology. The first important thing we'll be discussing is how pediatric airway differs from adult airway. Questions on this are very frequently asked. So, how does pediatric airway differs from adult airway? Characteristics of the pediatric airway. The pediatric airway or a child's airway, it is found that children have a short neck. So, children and their airway is unique. They have a short neck. It is found that children are found to have a larger tongue compared to the oral cavity. Children are found to have a larynx which is not only anteriorly placed, it is also higher placed. Higher placed is sometimes written as cephalad presentation. It is higher placed as compared to adult larynx. The narrowest part of pediatric airway is not at the glottis, it is at the subglottic region. So, potential MCQ, it is the subglottis. Sometimes they don't write subglottis, they write the landmark. So, it is subglottis which is at the level of cricoid cartilage. So, in front of cricoid cartilage, the subglottic region is the narrowest part of pediatric airway. MCQ on this has been asked in the past. Another important thing that children, the epiglottis is long and floppy and it is present at the level of C2 and C3 level, C2 and C3 vertebral level. Again, epiglottis is higher placed as compared to adults. Children, the carina, the branching of the bronchus into two parts is present at the level of T4 level, whereas in case of adults, it is present at the level of T2. And the carina is wider as compared to that of adults. So these are the features that have been asked in entrance exam, and you need to remember what are the two important MCQ things related to this that you need to remember. First thing, children are obligatory nose breathers. This is regarding the pattern of breathing. The anatomy part we have already done. Children are obligatory nose breathers. That means they do not breathe from the mouth unless some maneuver or something makes them do it. Children will get choked, young children particularly, but they will not breathe from the mouth unless they are made to do so by some certain thing. So they are considered to be obligatory nose breathers, and that is why bilateral nasal obstruction due to any reason can be a very problematic thing in these children. Secondly, there was a question asked some years back. Why are young neonates and infants able to breathe and suck at the same time? Now, sucking from the breast and breathing you cannot be done in a normal adult, but an infant is able to do both of them. How is it possible and why it is possible? It is possible because of the higher placed larynx and epiglottis in the child. And so, both the processes can continue together. So, you would write, children are able to breathe and suck together because of higher placed larynx, including the epiglottis. So these are the two MCQ points you can add to your notes. So after this discussion about the congenital disorders related to children, so after this discussion of pediatric airway characteristics, we move to the discussion of congenital pulmonary disorders. So we'll be discussing congenital pulmonary disorders. In congenital pulmonary disorders, we'll be starting with the beginning of the airway, that is the nose. So the first topic we'll be discussing is choanal atresia. Choanal atresia. Choanae of the nose. Whenever there is atresia, there is absence of lumen formation. Air cannot move from the external nares to the back of the airway and hence into the lower respiratory tract. That condition is called as choanal atresia. Choanal atresia, the first thing that you need to remember, it is the most common congenital anomaly of the nose. What exactly is choanal atresia? There is a congenital obstruction at the level of choanae of the nose which obstructs airflow. The condition is more common in females as compared to males by a ratio of 2:1. What is the reason? The cause? There are two theories which are responsible. Both theories have their pros and cons. One theory says that there is abnormal persistence of buccopharyngeal membrane. Normally, buccopharyngeal membrane tends to disappear with age, and if it persists in the postnatal period, that can cause choanal atresia. Second is failure of oronasal membrane to rupture. If it does not rupture physiologically, then again it can cause obstruction. Now the type of obstruction, the obstruction which is seen in these children can either be bony or membranous. Remember that bony obstruction is more common, seen in 90% cases, and membranous obstruction is seen in 10% cases. Now what are the types of choanal atresia? It can be of two types, unilateral choanal atresia, which is more common, and there can be bilateral choanal atresia, which is rare but more severe. Unilateral means on one side, the choanae, there is atresia, so airflow is not happening on one side. Most of the unilateral choanal atresias, they are found to be asymptomatic, and they come to attention in childhood or sometimes in adulthood when medical attention is sought for some other reason. That is when they come to attention. Whereas bilateral choanal atresia is the severe form and tends to present in the neonatal period. Remember that young children, especially newborns, are obligatory nose breathers. They cannot breathe through the mouth, and so if both the airways are blocked, there will be no airflow or very little airflow to the lungs, and so the child will develop cyanosis. When the child develops cyanosis, there will be hypoxia, there will be CNS irritation, child will start crying. When the child starts crying, he or she will open her mouth and inadvertently start breathing from the mouth during crying, not normally. So when airflow will happen through the mouth, through this open mouth, the cyanosis will improve. Now the child will be calm, the child will stop crying. When he stops crying, again he tries to breathe through the nose because it's an obligatory nose breather. So cyanosis will come back. So cyanosis appearing when the child is crying. So cyanosis appearing when the child is calm and cyanosis disappearing on crying is called as cyclical cyanosis. So remember, potential MCQ. Which condition shows cyclical cyanosis? Bilateral choanal atresia shows cyclical cyanosis. So what is cyclical cyanosis? I just explained the pathophysiology behind it. Cyanosis at rest but disappears on crying. Now, how would you identify? Know that this is choanal atresia if there is a clinical suspicion. Clinically, when you do investigation, there will be failure to pass a nasogastric tube. You try to pass a nasogastric tube, there will be failure to pass a nasogastric tube more than 3 centimeters into the pharynx. So this indicates, but the investigation of choice is always HRCT, high resolution CT scan, as mentioned in Nelson 21st edition. What is the treatment? Treatment is very simple. Unilateral choanal atresia needs surgical management, but surgery is done in late childhood whenever it becomes manifest and the finances are there. So it is a planned surgery. Bilateral choanal atresia requires emergency management because cyclical cyanosis is happening. So in bilateral choanal atresia, as a first step, you ensure either an oral airway or you intubate the child. And once you have intubated, you perform surgery in the neonatal period. During surgery, remember, we are doing things in an integrated manner, so surgery part also I am mentioning here. The surgery done here is the transnasal approach. Surgery done through the nose, through the anterior external nares. So transnasal approach is considered better, followed by transpalatal approach. So this finishes the topic of choanal atresia. Extra edge thing regarding choanal atresia. There are some syndromes associated with choanal atresia. The most common syndrome is Charge syndrome. Charge syndrome arises due to mutations in the CHD7 gene. What is the full form of Charge syndrome? Multiple times in entrance exam it has been asked. C stands for coloboma in the iris. H stands for heart defects. A stands for, now common mistake people make, they write anal atresia. No, it is not anal atresia, it is atresia of the choanae. That is choanal atresia, the topic we are discussing here. R stands for retardation of growth. G stands for genitourinary malformations or simply genital malformations. And E stands for ear anomalies. So this finishes the in-depth discussion of choanal atresia. A new thing has been added in Nelson 21st edition which you need to remember, can be asked as a rare thing. Sometimes rare things are also asked. Now when you do surgery for choanal atresia, often post-surgery granulation tissue forms and restenosis can happen. And it's a very fairly common problem. How to manage that? Studies have shown that an agent called as mitomycin C, it decreases granulation tissue formation post-surgery in patients of choanal atresia. and so it can decrease the chances of restenosis in the patient. Let us have a look at some images. As you can see in these pictures, this is the lateral aspect of nasal cavity which I have shown here. What happens in patients, this is a normal structure. In patients with choanal atresia, there will be an obstruction like this. So it will be either a bony obstruction or it will be on one side, in unilateral, both sides bilateral. This will not allow air entry to happen. So this is what is called as choanal atresia. Mostly it is bony. 10% cases can have a membranous obstruction as well. And here in this photograph, you can see there is unilateral choanal atresia. As you can see, there is obstruction visible. It is not that commonly seen, but sometimes unilateral comes to attention late. So these children, as late as 7, 8 or 10 years, they are diagnosed. When you perform rhinoscopy, you try to see like this, you will find that there is obstruction present here. You ask the child will say, I always breathe from one side, never breathe from this side. And then that is when the suspicion of this condition arises. There is patency on the other side, as you can see in this picture. Next, we come to a very important but small topic called as laryngomalacia. The name itself is suggestive of the underlying condition. Laryngo means larynx, malacia means softening. Over soft, over compliant, less tone of larynx is called as laryngomalacia. So laryngomalacia, the first thing that you need to know, this is the most common congenital anomaly of larynx. Second point, it is the most common cause of stridor in less than 2 years of age. Both of them are known previous MCQ points. So you can add these points to your notes. Now, what exactly is the basic problem in laryngomalacia? The basic pathology or the disease in laryngomalacia is over-compliant or soft upper part of larynx. This upper part of larynx is soft and overly compliant since birth. So, whenever the child forcefully breathes on inspiration, it gets pulled inwards, producing a partial obstruction. This partial obstruction produces stridor. And this is what laryngomalacia is. So let me give you an example. Larynx has 3 parts. You have the glottis, the vocal cord area, supraglottic and the subglottic part. It is the supraglottic part which is mostly affected. It is composed of cartilage. Cartilage should be stiff. It should not be overly flexible. In children who are born with laryngomalacia is not exactly a problem. It is more of a maturational delay. So what happens is the upper part of larynx is too much compliant, too much soft. So whenever the child will lie in a particular position, or when he is crying, or whenever there is upper respiratory infection, this loose larynx will get pulled inwards and produce partial obstruction. That partial obstruction will cause stridor. The characteristic of this stridor is it will sometimes become severe and sometimes it will go away. So we call it as episodic or intermittent stridor. As age advances, this stridor tends to improve because the underlying tone of the larynx tends to improve, and more than 90% children become absolutely fine by 18 months to 2 years of age. That condition is laryngomalacia. So this is the pathology. Most commonly affects which part of larynx? It most commonly affects the supraglottic structures above the glottis. In supraglottic structures, which particular parts are mostly affected? In decreasing order, I am writing, it mostly affects epiglottis, then it affects the arytenoids, and then it also affects the aryepiglottic folds. So in decreasing order, these are the 3 structures which are commonly involved. It is very rare for laryngomalacia to involve the subglottic region. What are the clinical hallmark? What is the clinical hallmark? The clinical hallmark of laryngomalacia is intermittent or episodic stridor. This intermittent or episodic stridor will be increased when the child is crying, when the child has an upper respiratory infection or when the child is put in supine position. It will decrease or disappear when the child is calm and when the child is put in prone position. So this is the clinical hallmark of the disease. Some patients may also have associated dysphagia, but the dysphagia is usually not as severe as the respiratory symptoms. There are many theories for the dysphagia to happen. One of them pertains to larynx and upper esophagus arising from the same structure, the similar structure in fetal life, and so sharing the decreased tone and abnormalities in motility. Larynx has decreased tone. Correspondingly, esophagus tends to show some motility problems, and associated dysphagia can sometimes be seen, but it is not the defining part and it is in fact not always present. What we always see in laryngomalacia is intermittent or episodic stridor. What is the investigation of choice? The investigation of choice is laryngoscopy. You will do direct laryngoscopy and you will find a classic finding called as omega epiglottis, also called as omega shaped epiglottis. How does omega look like? Like this. So the shape of the larynx epiglottis becomes something like this. Potential visual can be asked on this. So I'm putting a small v here. What is the therapy? What is the treatment? In most of the patients, you require reassurance of the parents along with observation. Why reassurance and observation? Because more than 90% people improve in 18 to 24 months of age. So it tends to improve within 18 to 24 months. If it is severe or persists, you can perform a surgical procedure. The surgery of choice is a procedure called as supraglotoplasty. Supraglotoplasty will be the surgical procedure of choice. So this finishes the small but important topic of laryngomalacia. Before we move further, let us have a look at the visual omega epiglottis. How does it look like? As you can see in this picture, this is a laryngoscopic finding of omega epiglottis. So it looks just like an omega. So this shape of larynx of the epiglottis is called as omega epiglottis. You find a picture like this and the history saying young child, intermittent stridor, onset in the first month of life and becoming maximal somewhere around 4-6 months of age. What advice would you give? Wait and watch, because this is laryngomalacia. After this, we come to the congenital lung disorders. Congenital lung disorders is a huge group of lesions, but not all of them are important. We'll be doing them in a very brisk, conceptual and point-based form so that you are able to identify and have a good strike rate if any MCQ is asked in the exam. So congenital lung disorders, the first thing that you need to know, which is a one-liner, is that lung is considered to be a foregut derivative. So lung is a foregut derivative. So all congenital lung disorders are considered to be foregut disorders. Okay, this much is clear. Now you will find terms in congenital lung disorders which are similar sounding. You find terms known as lung agenesis, term called as lung aplasia, and third is lung hypoplasia. They sound like each other, but they are not the same. What is the difference? Agenesis means that the lung and its related structures have not formed at all. See, obviously, bilateral lung agenesis or bilateral lung aplasia will not be compatible with life. So, they are not born at all. They are aborted in utero only, or they die within the first few hours of life. So, we are not considering that incompatible thing. They are mostly unilateral forms which come to attention, which are able to survive. Lung agenesis means, see, there are three components: lung tissue, bronchus, and the vessels of the lung. If all three are absent on one side, we call it as lung agenesis. So, in lung agenesis, the lung tissue, its vessels, as well as bronchus are found to be absent on the affected side, all three are absent, we call it as lung agenesis, right? If lung tissue and vessels are absent, but ipsilateral, that is same-sided bronchus is present, we call it as lung aplasia. So you will have bronchus. Imagine I say right lung agenesis. So right lung agenesis, what it will be? There will be no lung tissue, no vessels of the lung on this side, and no bronchus, no right bronchus, because this is right side, right? No right bronchus. That is lung agenesis. Lung aplasia, no lung tissue, no vessels, but there will be blindly ending bronchial tree on this side. That is lung aplasia. And lung hypoplasia, all the three elements are present, but the lung tissue is less, so it interferes with your gas exchange. So lung hypoplasia means the lung tissue, its vessels and its bronchus, they are present but hypoplastic. But it is found to be hypoplastic. So if I have to show you diagrammatically, this is, if I have to show you like this, what is this condition? Yes, it is present on both sides, but this side lung, as you can see, it is smaller in size, so this is hypoplasia of the lung. So this lung is hypoplastic. Second example, you may get visuals on this. Visuals on this are asked in MCQ, not direct MCQs, but difficult questions. If they have to put, they can put up a photograph like this. This is bronchial tree has formed, but no lung tissue has been formed on that side. So this will be aplasia. Okay. And the third variety, what is this? Not even bronchus has formed on the affected side. So this will be agenesis. So I hope this distinction between them is now clear. So let us now discuss a few points related to lung hypoplasia. Lung hypoplasia associations are asked in entrance exam. Older PGI questions, it has been asked, and a small chapter on this is dedicated in Nelson. So at least 3-4 points we need to remember. So the first congenital lung disorder that will be discussing is pulmonary hypoplasia. Pulmonary hypoplasia is associated with three common findings. Pulmonary hypoplasia can be associated with fetal oligohydramnios. So patients who are having, children who are having oligohydramnios in the fetal period, they have a high tendency to develop pulmonary hypoplasia. For example, can you give any example? Think of an example. Yes, it is Potter syndrome, which is due to renal agenesis. Second, you have, it is associated with congenital diaphragmatic hernia. Third common reason or association for pulmonary hypoplasia is asphyxiating thoracic dystrophy. It is also called as Duane's syndrome. Duane's syndrome. This is regarding pulmonary hypoplasia. The second condition that is important, which is an important congenital lung disease on which question in AIIMS entrance has been asked 2 times in the past, is congenital lobar emphysema. In your MBBS, you have read about emphysema. What is emphysema? It is dilatation and destruction of the lung tissue, producing largely dilated alveolar spaces. If it is congenital and affects only one part of the lung lobe, only specific lobe, we call it as congenital lobar emphysema. Congenital lobar emphysema is a congenital condition which occurs due to obstruction of one major bronchus branch in utero. Okay, one major bronchus branch in utero. So imagine left, you have a major bronchus dividing into right and left. Left ka there are further 2 or 3 divisions going to the lobes. One lobe, one branch gets totally occluded. It may get occluded, it may get obstructed due to maldevelopment. It may get obstructed due to extrinsic compression. It may get compressed, obstructed due to stenosis or kinking. What it will do is, because that part bronchus is now obstructed, there will be dilated lobe on the affected side. But since the disease occurred in utero, its development will be abnormal. It will produce a non-functional dilated lobe. So it will be a dilated non-functional lobe on the affected side. What is the most common site of development of congenital lobar emphysema? It is the left upper lobe. Putting it in different color because this is an MCQ point. Left upper lobe is mostly affected. How do these children manifest? Clinical features: they present with neonatal respiratory distress. So there will be tachypnea, retractions, grunting, cyanosis, and you will find, if it is because it is on the left side, so large dilated lung lobe on the left side will push the mediastinum, the heart, the apex beat towards the right side. So there will be mediastinal shift. When you perform a chest X-ray, you will find a large dilated mass, large dilated air-filled mass on the affected side, pushing the other side to the opposite end of the thorax. Treatment is simple. You need to perform surgical resection. Treatment is surgical resection. Look at this picture. What can you find in this? If you see carefully in this picture, you will find that there is a large cystic mass. I am trying to form the boundary of this. Large air-filled mass like this. Can you appreciate the boundary? Which is, it is the large dilatation of the upper part of left upper lobe, which is forming a congenital lobar emphysema, and it is pushing the cardiac shadow on the other side, and it is also causing compression of the contralateral lung. So what is the likely diagnosis in this? This is congenital lobar emphysema. So if I remove this description, just have a look clearly. Just try to see. They will always put it as a case. Newborn was found to have respiratory distress with mediastinal shift and an underlying congenital problem was suspected. There were no air-filled cystic lesions on the left side, but a large cystic mass, large air-filled cystic mass arising in left upper lobe was seen as shown in the chest X-ray. What is the likely diagnosis? So everything pointing towards congenital lobar emphysema. This is how it looks like. Treatment is surgical resection. The third congenital lung condition that we need to know is CPAM. CPAM stands for congenital pulmonary airway malformation. Earlier times, it was also known as CCAM. CCAM stood for congenital cystic adenomatoid malformation. But this term has been discarded now because not all of these lesions are cystic and not all of them show adenoma formation. So CPAM is the correct term for this condition. CPAM is considered to be the most common congenital cystic lesion of the lungs. So it is the most common congenital cystic lesion. What exactly it is? It is a hematoma. It is a hematoma or a dysplasia which is responsible for cystic change in the affected site. It is always unilateral and affects only one lobe. It is divided into 5 subtypes ranging from type 0 to type 5, ranging from type 0 to type 4, 0, 1, 2, 3, 4, 5 subtypes. Among them, the type 4 variety is the one which is associated with adenomas and malignancies. Potential MCQ. Extra edge point. What is the most common malignancy associated with CPAM? It is seen in only 1% of the cases, but if it is associated, there is a rare malignancy called as pleuropulmonary blastoma. So this is the association of CPAM, some of the rare forms. How does clinically they manifest? Clinical features, most of the CPAMs, they present with neonatal respiratory distress. Again, they will have mediastinal shift. So they have a presentation very similar to congenital lobar emphysema. But when you do chest X-ray, you will find there it was a air-filled cystic mass. Here you will have multiple cysts on one side of the lung producing mediastinal shift. So multiple small cysts will be visible instead of one air-filled structure. There you had one air-filled structure causing compression of the other lung. Here you have multiple cysts present on one side of the lung, and it commonly tends to resemble a close differential diagnosis is congenital diaphragmatic hernia. In congenital diaphragmatic hernia, you will have bowel loops coming from abdomen and coming into the thorax. So you will find similar presentation on the affected side as well as below the diaphragm, and the diaphragmatic shadow may be obliterated, whereas in patients with CPAM, the thorax will have cystic masses, diaphragm will be intact, and below the diaphragm you will not find any dilated air fluid masses suggestive of any intestinal obstruction. So these are the chest X-ray findings. However, many times chest X-ray findings can be confusing, and so you need to perform ultrasound or CT scan for definite diagnosis. So the treatment again in these patients is surgical resection. So we have seen the photograph of congenital lobar emphysema. This is how the photograph of CPAM looks like. Can you appreciate the intense mediastinal shift happening, and can you see small multiple cysts being present in this part of the lung? So all these are what we called as CPAM. The findings on chest X-rays take some experience, some time to develop. If you will get an X-ray, it will not be a pure X-ray like this. They will give a context, they will give a clue, and then you will have to make the diagnosis. It can easily be distinguished from congenital lobar emphysema because in congenital lobar emphysema, you have the left upper lobe involved and it is a single large black colored air-filled mass. Whereas here, you have small multiple cysts, and they can occur on left side, they can occur on the right side. They will produce intense mediastinal shift, but it will not be a completely single air-filled mass. So this is how CPAM looks like. And the fourth congenital lung disorder is pulmonary sequestration. Sequestration means separation. What exactly is pulmonary sequestration? There will be discrete or separated lung tissue with no bronchus. So no bronchial connection. No bronchus means it will be a useless tissue. It will not contribute to gas exchange. It will simply be a space occupying lesion, and they have abnormal vascular supply. The vascular supply in all of these lung tissues will be from branches of aorta. So that is called as pulmonary sequestration. Pulmonary sequestration is of two types. You have intralobar form, also called as intrapulmonary, and second is the extralobar form, called as extrapulmonary. Which is more common? The intralobar form is more common. Extralobar form is rare. Intralobar form commonly occurs in the lower lobes, but any lung, either right or left, can be affected, whereas extralobar occurs only on the left side. In intralobar, there is no separate pleura of its own, whereas extralobar has its separate pleura. Intralobar, the venous return goes into pulmonary veins, whereas extralobar, the venous return, blood supply दोनों का from aorta. Here the venous return goes into inferior vena cava. Intralobar is associated with other congenital malformations. in 50% cases, whereas extralobar, only 2% cases have associated congenital malformation. Both of them, intralobar as well as extralobar, are characterized by recurrent infections. And so, surgical excision is needed in. How to identify? The question will say, on the right side, you can find small cystic masses which on further investigation were not found to be connected to the main bronchus and were having aberrant vascular supply. They will give as a case and then show this picture. What is the likely diagnosis? This is pulmonary sequestration or simply sequestration of the lung. And if I ask you which variety of sequestration is it, intralobar or extralobar, it is intralobar variant. Why? Because extralobar only occurs on the left side. Here the right side is involved and that too the lower lobe, and which is more common, intralobar, the intrapulmonary part. So this is intralobar sequestration, as you can see in this picture. Again, on the basis of X-ray alone, it is very difficult to distinguish all these congenital conditions. That is why the points which I have mentioned, you will have an X-ray along with some of the statement mentioned, which will help you in reaching the correct answer. Integrated MCQ does not mean integration of 5 different subjects. That can happen. Integration also means within the same subject or within the same topic, 2 or 3 anatomy, physiology, radiology, clinical feature all combining to help you in reaching the correct answer. So it is an upcoming topic. All these congenital lung malformations, Nelson has separate chapters for them. So you can expect some difficult questions in NEET PG and next exams for your in your entrance preparation. Quickly we move to the infections of the upper airway. So after congenital part is over, we move to infections of the upper airway. In infections of the upper airway, you have two evergreen topics, croup and epiglottitis, always asked in exams. So the first one is acute laryngotracheobronchitis. In short, it is also written as croup. Acute laryngotracheobronchitis occurs in the age group of 6 months to 5 years of age. So young children are predominantly affected. What is the etiology? It is virtually always viral in nature. What is the most common virus producing laryngotracheobronchitis? The most common virus is parainfluenza virus. It can rarely also be caused by influenza, adenovirus, etc. Frequency? It is a fairly common condition and there are outbreaks of croup worldwide because it is a viral infection. Same members of the family may be affected. The other adult family members may be having simple viral fever, viral sore throat, and the children may tend to develop acute laryngotracheobronchitis. What is the clinical features? What is the clinical presentation of laryngotracheobronchitis? Initially, there is a viral prodrome. In viral prodrome, there will be low-grade fever, irritability, malaise, etc. Running nose, watery eyes, right? 1 to 3 days later, there will be onset of stridor. The stridor is initially inspiratory, later it may become biphasic as well. So severe stridor may develop. Secondly, these children will develop moderate grade fever. And the third feature is cough. The hallmark of laryngotracheobronchitis is the classic cough seen in these children. We call it as barking cough, also called as seal-like cough. So barking cough or seal-like cough, if you find this word, the answer will always be laryngotracheobronchitis. So they have a very characteristic cough. Seal is a mammal. So they are like dolphins. When their mating season comes, they produce a sound which that sound is similar to the sound which is seen in coughing of croup children, and so we call it as seal-like cough. So barking cough, seal-like cough, bark of the seal cough, they all refer to the same entity. It is mainly a clinical diagnosis. The respiratory distress in these children is usually mild to moderate. So respiratory distress is only mild to moderate. It is not severe in most of these patients. However, obviously, if you neglect the condition, it may become severe as well. What is the classification of severity? Classification of severity is something which is often missed. MCQs are asked because treatment depends upon how severe it is. So, classification of severity, we can form a small table here. There are three categories of croup. We have mild croup, moderate croup, and severe croup. First, we look at the general appearance of the child. In mild croup, the child is happy and feeds well. In moderate croup, the child is irritable. In severe croup, the child is anxious or has altered sensorium. Then we look at the stridor. In mild croup, the stridor is present only on coughing or exertion. In moderate and severe, stridor is present at rest. So this is very important. Then distress. We look at the respiratory distress. It is not present in mild. In moderate, there is modest respiratory distress. Books say, the classification says there is tachypnea and there are retractions. In severe croup, there will be severe tachypnea and severe retraction. And finally, SpO2, we look at the saturation of oxygen in the arterial blood. If it is more than 92% on room air, it is seen in mild croup. Here also it is more than 92% on room air. Whereas in severe croup, there will be hypoxia. So less than 92% on room air. This is the table which is extremely important. You must always remember it before you go to your exam. 1 week before the exam, make sure to revise this table for your exam. So this is regarding the classification of severity. So we have talked about the classification part. Now we come to the investigation part. See, investigation wise, Nelson says that croup is a clinical diagnosis. Investigations may or may not be done. But if they are done, you find a specific pattern. In croup, we perform X-ray, neck, AP view. In younger children, in older children, you can do the PA view as well. You know that PA view is difficult to do in a younger child because you have to hold the screen. So X-ray neck AP view is usually done, although the findings have been described for PA view. So let's not go there. Let's not go into radiology. Simply X-ray neck, see the view, not from lateral. If we do it, we find a sign called as steeple sign. Steeple sign has been asked as a visual in NEET PG entrance exam. It is a NEET PG question, so can be repeated in the exam. Steeple sign basically refers to subglottic narrowing. What is the steeple? Steeple is the ascending spire of a church. So there will be a subglottic narrowing, and then as you come down, the airway becomes broad. This is called as steeple sign. This is how steeple sign looks like. Can you see that I'll first try to form the boundary. This is how steeple sign looks like. Pointed at the top where there is subglottic narrowing, as it is coming down, it is becoming broader. So I'm removing it. Now see it carefully. The question will say 3-year-old child, barking cough, stridor, X-ray showing the following. This is the typical steeple sign. And so the likely diagnosis in this child, this is the classical steeple sign. And so the likely diagnosis in this child is croup. What is the treatment? Treatment is characteristic. All patients of mild croup respond to oral dexamethasone. So corticosteroids are considered to be the therapy of choice. Oral dexamethasone as low as 0.15 milligram per kg, single dose is good enough. Sometimes 2 or 3 doses can also be given. But mild croup responds to oral dexamethasone. Even in moderate and severe, dexa has to be given, but mild will respond to dexamethasone steroid alone. Whereas moderate and severe croup, you need to give racemic, epinephrine, that is adrenaline nebulization. Racemic mixture is a special mixture which has equal number of dextro and levo forms, and so theoretically it is said that it has less cardiovascular side effects. But current guidelines, Nelson 21st edition, they say if this racemic mixture is not available, you can safely use under monitoring the normal epinephrine, which is mainly L isomer, that also can be used. So through nebulized route, you give epinephrine. It acts through alpha receptors, precapillary receptors, and causes by multiple mechanisms, it decreases the laryngeal edema. So dexamethasone in mild, moderate to severe, drug of choice is racemic epinephrine nebulization. And if there is no response to nebulization, then you can give a trial of Heliox inhalation. Heliox is a mixture of 80% helium and 20% oxygen. It has been shown to decrease the airway resistance and improve airway patency. There is no role of antibiotics in croup. There is no role of antibiotics in croup. Old MCQ. Another MCQ asked in JIPMER entrance exam, taken directly from Nelson. Nelson mein there is a line which says the chest X-ray, the line says X-ray findings do not correlate with severity. That is why if you see the severity, mild, moderate, severe, we did not talk about the X-ray findings. It was the general appearance, stridor, respiratory distress and SpO2 that we took into consideration. So X-ray findings do not correlate with severity. It was a statement-based question asked in JIPMER entrance exam. So we have finished the entire topic inside out. Next we move to the second infection of the upper airway, that is acute epiglottitis. Acute epiglottitis is a very dramatic, life-threatening emergency situation. Acute epiglottitis fortunately is rare as compared to croup. What is the age during which acute epiglottitis occurs? Again, it occurs in young children, usually less than 3 years of age. But the age consideration has now been changing in view of Haemophilus influenza not being a common cause, as we shall see. What is the etiology of epiglottitis? It is caused by bacterial infections. Earlier, it used to be Haemophilus influenza, which used to be the most common cause. With H influenza vaccination coming, it is no longer the common cause, and all standard books, including the recent articles from Indian studies also, are very clear that the most common bacterial cause of acute epiglottitis is streptococci. It is Streptococcus pyogenes followed by Streptococcus pneumoniae. Whether India or world, the most common pathogens are streptococci. Frequency, it is considered to be a rare but severe infectious state. Coming to the clinical features, how does the disease manifest? In croup, there was a viral prodrome followed by onset of progressive symptoms. Here, there is no prodrome. It is characterized by acute onset disease. There is acute onset of high-grade fever with chills. There will be a toxic look at the child. You will look at the child and child will have a red suffused face and the child will look to be very ill. There will be stridor, but there will be no barking cough. This is important. There is no barking cough. There is severe respiratory distress, which is progressive. Two important things. There, the identifying point in croup was barking cough. Here, the identifying point is 1. Drooling of saliva. The child cannot swallow his own salivary secretions and saliva dribbles from the angle of mouth. It is such a painful condition because not only epiglottis, the entire pharynx is intensely inflamed and painful. So, drooling of saliva. And second, there is the child breathes in tripod position. Tripod position is also known as sniffing dog position. So, because edema is severe in these children, so whenever distress happens, they will lean forward, put their hands in the front and breathe deeply like this. This type of breathing, leaning forward, is called as tripod position breathing or sniffing dog position breathing. It is a bad sign. So, you find a case or you find a video or you find an image where the child is breathing like this with there is fever, stridor and drooling of saliva, likely diagnosis is acute epiglottitis. Again, just like croup, it is you don't wait for investigations to come. You find these features, you start treatment on the lines of acute epiglottitis, because if you delay, there is a chance the airway edema may become complete. You may not be able to even intubate the child later on. Complete airway obstruction is a known life-threatening complication in these children. So, but if you time and you are able to do X-ray, here you do not perform X-ray neck AP view. You perform X-ray neck lateral view. An X-ray neck lateral view will show a sign called as thumb sign. It is also called as thumbprint sign. Swollen epiglottis will form a thumb-like projection projecting into the airway. Again, it is a potential visual. Look at this image. In this lateral view, can you see that there is a swollen thumb-like projection coming into the airway? This is the swollen epiglottis. So, I'll try to form the boundary. This thumb-like projection, it looks like as if a hand is kept and the thumb is projecting inwards. That is why we call it as thumb sign or thumbprint sign. So, swollen epiglottis forming a thumb-like swelling seen on lateral X-ray is known as thumb sign. Remember that laryngoscopy should not be performed in acute epiglottitis because it can precipitate spasm of the airway. But if done, it shows an appearance called as cherry red epiglottis. So theoretically speaking, omega epiglottis was a feature of non-inflammatory condition laryngomalacia, right? Cherry red epiglottis is seen in inflammatory infectious condition called as acute epiglottitis. What is the treatment of acute epiglottitis? The first step in the management of acute epiglottitis is early elective intubation. First, you do airway management, secure the airway of the child, put the child on ventilator or positive pressure ventilation, and then you start the patient on IV fluids and IV antibiotics. Among IV antibiotics, third generation cephalosporins are the initial therapy of choice. Which drug to start in a patient with acute epiglottitis, drooling of saliva, was a neat PG question asked just a year back. So this is the management for acute epiglottitis. And then let us talk briefly about some one-liners from the other infections, the other upper airway infections. The causative agents are usually asked, so that only one-liners will remember here. If somebody asks you what is the most common cause of common cold, it is caused by viral infections. The most common cause is rhinovirus. Common cold, sometimes they won't write common cold. They will write it as acute rhinosinusitis. This is the technical name for common cold. So, acute viral rhinosinusitis caused by rhinovirus. If the question says acute pharyngitis, it is caused by viruses. But if they ask bacteria, the most common bacteria is Streptococcus pyogenes. That is group A streptococci. And if the question asks you what is the most common cause of acute bacterial tracheitis, old NEET PG question, it is caused by the evergreen Staph aureus. So with these infections in mind, we have discussed not only the congenital disorders of the entire pulmonary system, we have also talked about the upper airway infections. And if you see carefully, you will find that stridor is a common thing in any partial obstruction of the upper airway. So for MCQs, remember, I am just giving you some hint words here. If question says stridor, this is something you will not find in guidebooks. Remember, if the question says stridor, think of upper airway obstruction, right? If the question says no fever and onset in first 6 months of life, you will think of laryngomalacia as the likely possibility. There can be other rare causes, but they are beyond our purview. If the question says fever is present, look at whether the patient is having a barking cough or not. If there is barking cough, think of croup, that is laryngotracheobronchitis as the answer. And if there is no barking cough, instead there is drooling of saliva, tripod position, or fever with chills, you will think of acute epiglottitis as the answer. So this is very important for revision before you go for any exam, whether it is your university exam or your entrance based exam. So this finishes part 1 of this pulmonology module.